Greetings, everyone. My name is Tyler Hemmingson, and I serve as Senior Director of Practice Advancement for the American College of Lifestyle Medicine. On behalf of ACLM, we're honored to be with you today for a really unique webinar showcasing the ways that lifestyle medicine, shared medical appointments can deliver comprehensive, scalable, team-based, patient-centered, whole-person care. As our speakers today share about their work, please feel free to submit your questions and comments in the chat and the Q&A. Some of your questions will be answered via typed response, and some will be reserved for our live Q&A session. Looks like we're about a minute past the hour, so we'll get started here. We do want to recognize that one of the programs featured today, the Healthy Lifestyle Program, led by Dr. Jacob Mirsky at Mass General Hospital, is an ACLM certified program. Congratulations, Dr. Mirsky. To learn more about his program and other certified programs, please feel free to visit our certified programs page. And showcased here are a few of the learning objectives for today's webinar, centered around lifestyle medicine shared medical appointments. Having had the opportunity to collaborate with each of our presenters today on their programs, my encouragement for the audience is to identify elements of the lifestyle medicine shared medical appointment that seem to apply to kind of all care settings, acuities, and patient populations, as well as those that were really uniquely designed for the populations and settings discussed today. I imagine you may find value in both as you consider how some of these innovative approaches connect to your aspirations and the populations that you serve. Before diving into the webinar, let's start with a bit of framing. If you found yourself at today's webinar, you may already know the field of lifestyle medicine is centered around 6 evidence-based pillars or health behaviors, and those are whole food plant predominant nutrition, regular physical activity, restorative sleep, stress management, positive connection, and avoidance of risky substances. And as you've likely gleaned from the learning objectives, today's webinar will showcase a variety of approaches to lifestyle medicine shared medical appointments that address chronic disease, which utilize the group visit clinical delivery model. Group visits first appeared in the literature in the 1970s. They oftentimes involve a primary care provider and various interdisciplinary team members supporting a cohort of patients, as you'll hear about in more detail later today. When that group visit is centered in evidence-based pillars of lifestyle medicine, we call it a lifestyle medicine shared medical appointment. So without further ado, I'm thrilled and honored to introduce 4 incredible speakers for today's event. Dr. Ann Kodani, who is an internist practicing at Kaiser Permanente, Santa Clara. Dr. Devyani Hunt, who is a musculoskeletal physiatrist, medical director, and professor at Washington University's Living Well Center. Dr. Jacob Mirsky, a primary care provider and medical director at Massachusetts General Hospital Revere Healthcare Center. And Dr. Kathleen Finley, lifestyle medicine physician at Western Wisconsin Health. I could speak at length about the remarkable leadership and accomplishments of each of these phenomenal board-certified diplomates. And in the interest of time, I'll simply share that each brings an exemplary track record and has made an extraordinary impact on the future of care within their systems. So with that, I'm honored to transition to our first speaker today, Dr. Ann Kodani of Kaiser Permanente, Santa Clara. Dr. Kodani, over to you.
Thank you so much, Tyler. And I'm coming to you from the San Francisco Bay Area. Maybe some of you are from there. And I'm part of the lifestyle medicine leadership team here at Santa Clara Kaiser, which is led by our amazing director, Dr. Allison Collins, who's developed all the programs I'm going to talk to you about today, along with our lifestyle medicine team. Before we get started, I just want you to ask yourselves, if you haven't yet, are you wanting to start group shared medical appointments in the near future? And if you're wondering if it's the right option for you, even if you're not in a large HMO setting like we are, please take a listen, because I'm going to describe 3 different programs that we are currently using. And we've gone through iterations and definitely growing pains. And we'd love to have you use our experiences to help you in your lifestyle medicine practice. Okay, next slide. Thank you. And all of these programs are billed as preventative lifestyle medicine group appointments. And the first program I'm going to describe is one called Pivio. Next slide. So Pivio is a company that we partner with, and we use their intensive lifestyle medicine program platform to do these group shared medical appointments. And they have PowerPoint slides, they have teaching agendas, and for our patients, a web-based app that they use throughout the program. And it is a 12-month program, and we have up to 30 patients in each cohort. And they all have some sort of medical diagnoses like overweight, obesity, hypertension, prediabetes, etc. And these are mostly virtual appointments. So even though it's a year-long program, the most intensive part is in the first 3 months. So in those first 3 months, we meet 18 times. Only 3 of those are in person, the rest are virtual. And it's led by a board-certified lifestyle medicine physician with either a clinical health educator or a pharmacist who are both well-versed in lifestyle medicine. And we start our patients off out with a bang. Week 2, we do what's called a 5-day fresh start, which is we challenge our patients to eat a completely whole foods plant-based diet for 5 days. In that week 2, we do meet in person so people can meet each other, have some community. We do a cooking demonstration, and they do some hands-on cooking. They'll make like a spice blend or chia seed pudding. And then we'll go over content for that day. And then we end with giving them a food box. And a food box is a curated selection of produce, some nuts and seeds, pantry staples, and a recipe book. So literally they can use those pantry staples in that food box, and we give them the recipes to actually make a meal. And then we have quarterly potlucks, so people can come in. They'll bring in a whole foods plant-based dish to share. And also, of course, that builds wonderful community. And then before, during, and after the 12 months, we will have labs and biometrics collected. Next slide. So while we facilitate these sessions, it's not just about teaching content, and it's building safety and community. And all of you know this in some way, the residency or going through your training, is that there is really nothing like going through a challenging growth experience with peers that support you, especially in those really hard moments. So that's really the power of group shared medical appointments. In addition to teaching the lifestyle medicine pillars, which we all know about, we really emphasize behavior change techniques. Next slide. Because it is not just learning what to change, it is how do you actually change this? How do you build sustainable habits and break those habits that you don't want? So this is an incredibly important part of a curriculum, and not just Pivio, but all of our lifestyle medicine programs. All right, and as a Pivio facilitator myself, it's been one of the most rewarding parts of my career. And next slide. And we've had over 200, I think 40 patients go through our Pivio program within the last 2 years. And we've had statistically significant improvements in BMI, A1C, blood pressure, LDL, as well as liver transaminases. We've had high patient satisfaction and a retention rate of about 94% throughout those 12 months. And for those patients who have had mood symptoms, we show significant improvement in their mood scores. And I will say it's an honor really to see the patients transform themselves throughout this program. Next slide. So that's one of our intensive programs. What's another one? So maybe you're looking for a group shared medical appointment option and you have more limited time. So this may be a good option for you. Next slide. So the HEAL part of our Heal to Thrive Academy stands for Healthy Eating, Active Living. And this academy is run by a board-certified lifestyle medicine physician, and we meet once a month for 6 months with a curriculum. And there are in-person options, which is usually about 10 to 15 people. And then the virtual option, you can certainly add more folks. Next slide. The curriculum includes both content about lifestyle medicine pillars. So it can be, for example, healthy weight, managing fatty liver, but we also include an interactive activity. So that could be a cooking demo with hands-on cooking for those who are in person, or it could be something like food label reading, or how do you order out when you're at a restaurant or on vacation, or even an exercise activity, especially if you're in person, but also if you're virtual as well. So this curriculum runs for 6 months, and then we repeat it again for a different cohort. So a great option if you have more limited time and are really looking for something to build that community, but also do some interactive sessions as well. Next slide. Finally, I'm going to discuss our Heal for Families. This is a really exciting new program that Dr. Collins has developed in the last year. Next slide. So that HEAL part again, healthy eating, active living. And the patients' families, or the families, are really referred by the child's pediatrician. So the child's pediatrician will refer a family to this program. And what they will do is meet monthly for 90-minute sessions in a group, so with other families. And they'll have a cooking and a nutrition session with a registered dietitian and a physician that is board certified in lifestyle medicine. And then while the kids are exercising with a physical therapist, the parents will meet as a group with either a clinical health educator or a psychologist to really discuss the challenges that they have and how to overcome them, and then really get support for building those lifestyle medicine pillars as a family. And then every family will leave each session with one of those food prescription boxes like we previously described. And what we found is that there's been tremendous success in labs and biometrics for not just the child, but their family members too. And again, a truly incredible experience to see transformations in the family and really to see them heal. And on the event horizon is group shared medical appointments for adult and family medicine. So we have over 70 board certified lifestyle medicine physicians here at Santa Clara Kaiser, and we'd love for us to be able to share this passion and this ability to have group shared medical appointments with other physicians in our group. So it is going to be led by a board certified physician. We'll have guest speakers with subspecialists like GI, dermatology, cardiology, and then develop cooking demonstrations as well. So that is hopefully going to start this year. So that's on the event horizon. And I really want to end with something that isn't easily shareable as a data point. The true glue that holds these programs together and that makes them work is the people on our lifestyle medicine team, including our small support staff. And so we have many different personalities and strengths in our team, but we all share that same shared goal and passion for lifestyle medicine, and we all are there for each other. So if you can build a team, no matter how small, that has those characteristics, you will find a path to success. Thank you for letting me share that. And I'm so excited to hand it off to Dr. Hunt.
Thank you, Anne. That was fantastic. What an impressive program you all have there. So we are going to shift now to the middle of the country in St. Louis, Missouri, and I'm here under the arch today. And I'm part of the WashU Medical School, Department of Orthopedics and Division of Physical Medicine and Rehabilitation. And so I'm excited to tell you about the programs that we are using or have and how we're using shared medical appointments for scaling as well. So next slide. So we'll give you an overview of the Living Well Center and how we've set things up and in relation to how we are engaging in the pillars of lifestyle medicine for musculoskeletal disorders, and then our utilization of shared medical appointments, a few of the research projects that we've been working on, and a little bit of discussion of the revenue. So as I said, we are here at WashU in the Living Well Center. It is an academic setting, which has some pluses and minuses and associated with it. And we've been a pilot center and program since 2018. And then we opened our brick and mortar in June of 2020. Dr. Heidi Prather is our founder, and I'm the medical director. Next slide. So in an academic setting, we do have kind of the three pillars of academia. Our clinical focus is a true interprofessional team. And as you can see, we have people from all walks of the healthcare world, from our musculoskeletal care, which is delivered by myself and my partners. We have a nurse practitioner that works with us as well, and then to nutrition, counseling, an acupuncturist who's also my partner, and I do some of it as well. We have an athletic trainer, and then our nurse practitioner provides our smoking cessation classes. On the education side, we are blessed to have many learners that come through our program, and so we're able to inflict upon them or broaden their horizons on lifestyle medicine and how to use it within the orthopedic world. And so we have residents and PM&R, ortho interns. We have people that come through on the internal medicine side. Our fellows come through as well, and interns from other disciplines. And then our research director is my partner, Dr. Abby Chang. And so we've been able to publish our story from our feasibility story into our characteristic story, and then predictors of engagement on our interprofessional team as well. And that's been a wonderful way to tell our story. So next slide. So at the Living Well Center, we have a few different tracks that most patients will fall into. Some of them kind of cross over different tracks, but in general, this is kind of the way things lay out. And in general, as you can see, our largest track is health optimization. We also have a long COVID track, which over time is decreasing, which we like to see, but still there's a population patients that this model of care can be very helpful for. And then sitting in the surgery department, we are able to help our partners optimize their patients to surgery. Some of them are trying to avoid surgery, and then we have a chronic disease and persistent pain pathway, as well as a cancer survivorship pathway. Next slide. So this is a general overview of how patients enter our program, just to get an idea of how we use this in the musculoskeletal world. So as patients come in, we'll assess their lifestyle measures. We use PROMIS scores for pain interference, for pain, so for depression, anxiety as well, and then risk assessments on what parts of their kind of comorbidities we need to focus on dependent on their goals. And so we have a full evaluation by one of the providers, musculoskeletal providers, as well as our nurse practitioner, and then set up a pathway for them to achieve their goal. And that can be working with any of our providers, whether it be the dietitian, counselor, or maybe all of them. And then one thing that's been instrumental in allowing us to provide this in a way that can be scalable is to use our shared medical appointments. And so we're delivering a lot of our programming within the shared medical appointments. Most of our patients are in our program anywhere from 150 to 180 days, and then optimized and graduated with the tools for self-management. And that's certainly part of our goal, is to give them what they need and build their community so they can continue their adventure. Next slide. So this is a overview of our shared medical appointments, and over the years it has grown. We actually started with that first one, Lifestyle Adds Medicine, and it has then kind of blossomed into all of the other shared medical appointment offerings. And we guide patients in kind of sending them to these specific shared medical appointments through the week that we think would be helpful for them. Some of them they can choose to be part of, and then some of them are just kind of part of the program. But as we've found that being able to provide this, again, creates a community for patients to move forward. I won't go through each of these, but as I can give you some of the details on the programming. But as far as the Lifestyle as Medicine program, it is 8 sessions that we meet weekly. It's led by our nurse practitioner or physician. And then our dietitian, our counselor, our athletic trainer, they come into the programs as needed dependent on the topic. So we typically start with the kind of why and how of lifestyle medicine. We talk about sleep, we talk about movement. We have a few more nutrition sessions, and with hands-on cooking demonstrations. We hold these within a shared space that also houses our kitchen. So we can do this in a combination of in-person and virtual, which has been very helpful to be able to accommodate patients' needs. So from that, we've developed all the other ones, Seeing a Need. And so we have our weight loss program that's focused more on weight loss. This one is led by our dietitian. And then we have a pre-surgical optimization track. This is one of our programs that don't necessarily need a full first consultation with one of us. It's more so to help those patients who have a surgical date become healthier, to decrease, outcome, or to improve outcomes and decrease any comorbidities going into their surgery. And then, as you can see, we've got a full offering of options. Our newest one that's coming online next month is our sleep optimization for chronic pain, and we're excited to kick that one off. Next slide. I put this up here too because, as always, again, when I talk to my referring partners, especially in the orthopedics world, that they don't quite understand how the shared medical appointments work, although they're getting more used to them, that we do, it is different than our exercise classes. So through the shared medical appointments, we are billing as a return visit, but we also offer these exercise classes to help the movement sessions along. And one of our newer tracks within the Living Well Center is our female athlete track. So pulling together all the things outside of the musculoskeletal care that they need, such as dietitians, counseling, and all. And so this is another exciting area that we've been working on. Next slide. This is a little bit of our satisfaction data for shared medical appointments. And as you can see, most patients are highly satisfied. They think that that's useful information and they're likely to recommend it. We have really great responses from patients. And again, they appreciate that there are options for in-person as well as virtual. Next slide. I had mentioned some of our publications. This one is of note that we actually, to take a step back, we a couple years ago published a qualitative study on the perceived value of an interprofessional team and how we get together once a month to discuss patients, to learn from each other, to kind of help the programs move forward. And then we went back and did a qualitative study on patient perceived value of an interprofessional team. So we did some very focused interviews and found themes. And in general, patients really do find that there's benefit to having this multidisciplinary interprofessional approach. And they realize that we do get together and talk about them, and that does help them feel like they can move forward together, and they enjoy this integrative approach. One thing that was very interesting that came out was that this group and virtual programming formats were preferred by patients with greater social deprivation. The location of the Living Well Center, hard to get there, transportation, all the other kind of factors that go into it. The virtual format was definitely used in those with greater social deprivation. And then the other theme was that it was enthusiastic, authentic clinician support was key to their journeys. Next slide. This is also a publication along the same theme, that shared medical appointments improve equitable access to rehabilitative care for our long COVID programming. And some of the comments that we got too is that, again, it was difficult for those especially that are burdened by the fatigue of long COVID, it was difficult to get to appointments. So having the virtual option was helpful. We also found that it was really helpful to have these virtual and in person, if they can make it, programming in the morning. As the day goes on, some of these patients have a harder time being engaged. So this was an interesting paper as well. Next slide. I just wanted to show just a little bit about how kind of logistics, if you're not as familiar with shared medical appointments, and how it can really be helpful for the overall kind of financial stability of the center. So we do code our visits mostly as 99213. So a return visit with either our nurse practitioner or one of the physicians. Every once in a while, if it's a more involved and smaller one, then we might code it as a 99214. And in our programming, we only bill with a nurse practitioner or the physician assistant or MD or DO. And in other places, there's some shared billing options with dietitians or counselors, but we found that reimbursement wise, it made sense to us to be able to do it this way. But also making sure that we kind of give credit to the dietitians, the athletic trainers, and all that are involved in the programming. But for the billing side, it comes from that. There's a really high reimbursement rate. I put some of our totals here down for our fiscal year 24 and 25. As you can see, our collection rate is 51% for fiscal year 25, and 24 is 60, which is really quite high in our world. Otherwise, we're typically down in the upper 30s or so. So the overall reimbursement rate is high. You can see our shared medical appointment programming has increased over the years as we've added more, and that's been very helpful. So we do think that because to make it more profitable, we do hope that at least with 6 patients per shared medical appointment, and it usually takes about 1 to 2 hours. And next slide. So I will now turn it over to Dr. Mirsky, and thanks for listening.
Thanks so much, Dr. Hunt, and thank you everyone for participating today. Thank you to Tyler and the ACLM team for hosting this. One of my favorite things to talk about at work is shared medical appointments. So I'm really delighted to be here to talk about our Healthy Lifestyle program at the Massachusetts General Hospital. I've been the medical director for the program for 4 years, and really happy to share a bit about our progress and evolution over those years. On the next slide, I just want to highlight, though, that even though we are a very well-established program, and in fact, the largest lifestyle medicine shared medical appointment program in the country, I have to acknowledge that this is standing on the shoulders of giants. So Dr. Stephanie Eisenstadt was the first physician at MGH in primary care who led shared medical appointments back in the year 2000. Dr. Helen Delacatsios and Dr. Amy Wheeler were really critical for moving the shared medical appointment care delivery solution forward at Mass General. And I have to thank our tremendous team. We have an 8-person team on our Healthy Lifestyle program, and every one of them is critical. So what I'm going to show here is really the evolution of our program as we have built it up and tried to develop a scalable solution that works more broadly. So next slide, please. So our conceptualization of the shared medical appointments is really between periodic ambulatory care that is relatively infrequent, relatively low touch, and some intensive lifestyle change programs, which you've actually heard about already from previous speakers. So the sweet spot for our program is right in the middle here, where we've developed one-time lifestyle medicine shared medical appointments and lifestyle medicine shared medical appointments series with health and wellness coaching that meets the sweet spot of accessibility, but also engagement. So we want to be able to reach many patients across MGH primary care, but not make the burden so high that patients aren't able to engage. Next slide, please. All of our virtual group visits are run in the exact same way. In the 60 minutes that we have with patients, our average right now is 7 patients, we divide it into 2 halves. The first half of all of our virtual group visits, we call them VGVs, is didactic. So we've developed our own materials that we share on a screen, just like this is a one-to-many approach to sharing important information, and really important then to highlight the key information related to chronic disease basics, lifestyle medicine, guidelines and recommendations for chronic disease management, and also strategies for behavior change. So during the first 30 minutes, we are sharing key information that is just really too hard to deliver in a very short, very consolidated 15-minute primary care visit to make sure that patients are empowered with knowledge that they can take forward. Next slide, please. In the second half of all of our VGVs, we transition to individual patient check-ins. This is really important for 2 reasons. One, it's an opportunity to give patients direct attention so they can advance their own care plans and ultimately improve their health. So during these check-ins, everyone in the virtual group visit is listening to all the other participants, and we're focusing on behavior change goals, lab review, or medication management. So patients are really getting a lot out of that experience with all the other patients listening and learning to that experience as well. The other key benefit of doing these individual check-ins is that we then have enough information and appropriate information to be able to document and bill for these visits as individual follow-up visits, as you just heard from Dr. Hunt. Next slide, please. So here's an overview of our model. All of our virtual group visits are run by a physician or nurse practitioner in primary care that's paired with one of our health and wellness coaches. Each patient visit is typically billed then, as I just mentioned, using 99213 or 99214 codes. And the justification for this is the standard AMA template for medical decision making, not based on time. So every single time a patient comes into a VGV, we are ensuring that they are meeting the necessary medical decision-making criteria so that we are able to bill and get reimbursed for a follow-up virtual primary care visit. All of our patients then have free one-on-one coaching that's available to them after the VGVs, and then they're able to participate in additional VGVs as time goes on. Next slide, please. So with that understanding of the model, I'd like to transition and just share a little bit about the program as a whole. So we now offer about 30 VGVs every month. We have 15 primary care providers, nurse practitioners, and physicians, and 4 wonderful health and wellness coaches who are embedded into the groups, but then also available for the coaching afterwards. Since 2020, when we launched our virtual group visits, we've had over 3,500 EPIC referrals into our program across MGH primary care. This is for both English and Spanish programming. We've had over 12,000 scheduled visits and over 2,000 unique patients who have attended our programs. We currently offer 9 different program types. Most of what we offer are 4-part series focused on chronic disease care, as you can see in bold here. So we focus on hypertension, prediabetes and diabetes, obesity and GLP-1 receptor agonist medications, hyperlipidemia, and brain care, which is stroke and dementia prevention. We also have one-time sessions that are offered on a rotating basis for stress reduction and nutrition for health. And then we have one-time sessions for gastroesophageal reflux disease and insomnia. Next slide, please. So for all of these patients to actually get into their program, we have a very well-established recruitment strategy that includes many different approaches to patient education and also referral opportunities. First and foremost, we rely on providers in the primary care clinic to educate patients about all of our programs and give them information that they can then explore on their own. So these flyers are up in every clinic. Patients can then either go into the patient gateway to schedule themselves, they can call to talk to one of our patient service coordinators, or they can scan the QR code. This QR code goes to our website, which you'll see on the next slide, please. And our website has a live updated calendar of every single virtual group visit that we're going to be offering in the future. So we really want to make this very patient-centered and very expansive as far as how patients can get it in and when patients can get in. We offer groups in the morning, midday, afternoon, and evening. We offer it Monday through Friday. And so we really want to empower patients to find what's best for them, either for the first group that they join or for subsequent programs if they want to continue the journey with us. Next slide, please. This is just a snapshot of the patient gateway self-scheduling feature. So again, any Mass General Hospital primary care patient can open up their patient portal. They will be able to schedule their own visit. And you can see here on the bottom, it says MGH Lifestyle Medicine Virtual Group. And then they have the opportunity to click for themselves which groups they want to join. Our team then does some screening on the back end to ensure that patients who sign up for the hypertension series actually have high blood pressure or hypertension diagnoses. But for the most part, we really want to empower patients and lower the barriers to entry. Next slide, please. So many patients, many people often ask me about what our program actually looks like when patients are sitting in a virtual group visit with our team. What will they see and what will they feel? So I'm just going to show a couple slides to demonstrate what we actually do during those 30 minutes of didactics and the 30 minutes of the individual check-ins. So next slide, please. So this is from our hypertension series. I encourage anyone who's building their own programming to really use lots of infographics, minimal text, and rely on the hard work that organizations like the American Heart Association, the CDC, the NIH, they have put into creating great patient-facing materials. So in our hypertension series, we start just with a basic definition of what is blood pressure, what is high, and what is normal. Next slide, please. We also talk, for example, when we're focusing on plant-based nutrition, we give high-level overviews of where sodium comes from, how much the average American consumes, and use this as a basis to then introduce more concepts around plant-based nutrition. Next slide, please. So this is from our didactic component. As we transition to do the individual patient check-ins, we create a patient slide in all of our 4-part series that is a summation of their behavior change goals, called SMART goals, that they create and modify as they go through our program. We then have biometric data, whether it's their home blood pressure readings or lab testing, that we summarize for patients as well. And then appropriate medications are listed too. So after a coach does an individual check-in, let's say with a patient here, and they come up with a SMART goal to increase physical activity to help bring their blood pressure down, I, as the physician, if I'm leading this group visit, can then talk with the patient about their blood pressure readings, try to get an understanding of why some of their readings were in the 110s and some were in the 140s, ensure that they're taking amlodipine as listed here, and make sure they're not having any side effects. And because I'm engaging with the patient around their chronic disease care, bringing together behavior change goals and medication management, I can then bill for this at a higher level of care, the 99214 that Dr. Hunt introduced just previously, because we've built our programming to ensure a higher level of medical decision-making. Next slide, please. I'll finish up with just a few slides of research that we've done. Hypertension is really our flagship program. The first research study we did on this program, we published 3 years ago. And on the next slide, you'll see in this retrospective study looking back on patients' home blood pressure readings, a typical patient we still see. I'm actually about to launch a 4-part series in just a couple hours. We typically see patients start with an elevated blood pressure, which you'll see on the left here. During the series, their blood pressure comes down, and then they sustain lower blood pressures after the series. We calculated this and estimated it as well, and showed that there is a significant decrease in average blood pressures. Here you'll see that there is also an increase in the percentage of patients who meet the goal of 130/80. Next slide, please. And then also from this paper, we showed that not only were patients lowering their blood pressures in our programming, but it was actually in the setting of deprescribing medications, in contrast to a lot of programs where blood pressure medications are increased. So during the 4-part series, when we studied this, we actually showed that 59% of patients decreased their blood pressure medication, and almost 1 in 5 came off medications completely. Next slide. I'll finish up with our most recent research analysis, which we actually submitted this morning for publication. This is a much larger match-controlled study looking at the impact of our programming versus patients who were referred but never attended. So among 400 patients, we looked at a control and found that the average blood pressure reduction in our patients who attended was almost 5 millimeters of mercury lower than those who were in the control group. Next slide. So in summary, we found that virtual group visits are a wonderful way, as you've heard already, to engage patients and get a lot of useful benefit from having more time to provide guideline-driven care. All of our providers, we've now trained 20 in primary care, have loved running virtual group visits, and we continue to have 15 of the original 20 that we trained. Access is something that we highlight to our hospital leadership, that we are creating access for chronic disease care at a time when our primary care system is overloaded. And then we've demonstrated financial benefits from the incremental revenue, meaning the extra number of dollars that we can pull in by seeing 7 patients in an hour as compared to 2. Just related to the scalability, we have grown from a small team many years ago now to a larger team. And on the next slide, I just want to highlight that my goal in my career right now is to ensure that others have the ability to do the same, to scale up lifestyle medicine shared medical appointment programming. And in that vein, we have now all of our program materials, PowerPoint curricula, note templates, operational workflows, recruitment materials. All of this is now available for other people to use through a licensing process through Mass General Brigham, the parent company for my hospital. So hopefully you won't be reinventing the wheel anytime soon. And if you want to learn more about our program, every year we run a 3-hour virtual pre-conference workshop at the Herbert Benson MD course in Mind Body Medicine that's coming up this fall. So thanks so much for your attention, and I'm going to pass it off to my colleague, Dr. Finley.
Well, thank you so much. What an incredible presentation that we've heard on lifestyle medicine, shared medical appointments. And again, you know, as Dr. Mirsky said, what he built was on the shoulders of folks at Mass General. What I built, have been able to build with a team is due to people like Dr. Mirsky sharing his knowledge on this, and ACLM for supporting all of all of us with knowledge about this. So I'm glad you're joining us today and hope that you can find some great takeaways. I am sharing from Western Wisconsin Health, a small independent critical access hospital and rural health clinic. I returned home to my hometown in Western Wisconsin about 6 years ago and joined a team of dynamite lifestyle medicine minded folks, a health and wellness coach and a registered dietitian who were doing some work, but it was cash-based at the time. And we sought to support our population by developing a sustainable model. And we found that lifestyle medicine shared medical appointments does just that. And over the course of time, through multiple iterations, as you've heard from the other speakers, we've come to a place where we deliver a shared medical appointment series weekly. Patients join us for 13 sessions, and we enroll them continuously. We're in a small setting, so we don't have the ability to wait to accumulate a whole cohort. So we just enroll continuously throughout the year. Whenever patients are ready, they can enter into our model. They come to us in clinic, and I see them with either the dietitian or health and wellness coach, and then we get them enrolled into our shared medical appointments through an orientation session that does some level setting on nutrition, and then they enter based generally on a time slot that they find works for them, and they'll pop into wherever the series is, and over the course of time, we'll get all of those modules. We also have a diagnosis agnostic program, meaning we don't bring in patients just based on a certain diagnosis, hypertension, et cetera. We take all comers and put them into the group that fits best for their time slot. So we may have a cohort of patients in a session that includes somebody that was referred from behavioral health for their depression, somebody that was referred from endocrinology for weight management, and somebody else that was referred from ortho for prehabilitation, and kind of all comers in our small setting. We found this to be incredibly powerful to support our patients in their changes. Instead of being there based on diagnoses, I'm hypertension 1, you're hypertension 2, we're Dan and Wendy and Katie and Joe, and everybody is working together for their shared lifestyle change. This has turned out to be much more impactful than we recognized in helping to care for our rural population with limited resources. We tend to receive a lot of referrals for high utilization patients who need a lot of assistance with their care management, and we don't have a lot of resources within our setting. So we have the privilege to get to know these patients quite well because of their frequent touch points, and are able to help guide in their care navigation and connecting them to the resources that they need. I will state that the delivery model for us is all in person because we operate in a rural health clinic, and so using virtual visits is not a valid option for us at this time. Next slide, please. So when we first designed our program, we really just wanted to meet with patients, but over the course of time, we started to recognize the need for outcomes tracking and really have put a lot of intention into this in the last 3 years. Administratively, we have been needing to demonstrate to the administration our volumes as well as revenue generation so that we can continue to do this work. We had a really forward-thinking organization that said, yes, we'll take the risk of trying to introduce this, but in order to sustain the program, we've had to look at this. Really exciting. In the last couple of years, things have really taken off, and we had 289% growth the year before last from where we were trying to relaunch the program after COVID. And then in the last year, still 23% growth in the number of weekly encounters. Over the last 2 years, incredible growth in our unique patient population. We have a small staff. As I said, I joined an RD and a health and wellness coach, as well as a dynamite medical assistant who helps us to track these outcomes. We're pretty limited in our data extraction as well as analysis capabilities in our small organization. So relying on the team just to input data into Excel and be able to manage and track that. Again, satisfaction, I think you hear this across the board with lifestyle medicine shared medical appointments, is incredibly high. We also have a lot of interest in our retention rate. When we first started the program, we had 4 sessions and did expand to 12 based on input from patients as well as the needs of the community. But as you can see, the completion rate of 9 or more SMAs is only 47%, but in a population like ours, that's actually pretty good, and we see that number continuing to rise. I think a lot of that has to do with the learning we've had as a team on what patients need in those settings, how the curriculum is designed. We just did a curriculum redesign. We've created our own curriculum, and I echo what Dr. Mirsky said, using a lot of infographics, making it very simple. Over the course of time, we have really simplified the delivery method and worked to incorporate a lot of time for shared discussion and decision-making. Here's one of the statements that our patients shared in their anonymous feedback, that the need to minimize or the ability to minimize invasive sickness care. So really proud of that vision being captured by patients as well. We wanted to track quantitative outcomes, but as I said, in our small organization, it's really challenging. So we struggled with this, and actually our current president, Dr. Padmaja Patel, talked to me a few years ago at one of our conferences and said, just start putting whatever you can into Excel and build a database. And so that's what we do, is we hand jam into Excel because we're not able to extract out of the medical record efficiently. But we track 15 outcomes, including promised quality of life. We have a lifestyle assessment that my partner, Lynn Hueskamp, our health and wellness coach, and she's MPH trained in social behavioral change. She created a tool that we use to track self-efficacy change for our patients. And we believe that's the most impactful outcome in this lifestyle medicine shared medical appointment. We also track GAD-7, PHQ-9. And we evaluate these quarterly with patients. We have them come into clinic and follow up with us. And then we also provide those by inputting them into the chart and sharing them with the patient directly, and creating graphs, as well as sending those back to the referring provider to see the progress their patients are making. And then we are now tracking aggregate changes. We don't have any great statistical validity at this point because we're really just starting to look at that, but some exciting changes already that you see there listed. These are just a few snippets. Our population tends to stay engaged with our program. Again, I've been back in the organization for 6 years, but we had a pause due to COVID. So we have a patient who's been with us now for 4.5 years and continues to follow quarterly. He actually functions as a volunteer for our program. So he attends 3 of our shared medical appointment sessions per week and supports the other members as a peer support. And that is a growing program, and we find it incredibly impactful for supporting our work as well as supporting the other patients that are involved. Next slide, please. And again, reimbursement pathways. We do all of our work collaboratively with the health and wellness coach and the registered dietitian. However, we don't bill for any of their services. So all of the billing within our program is done by myself. And so the revenue that we generate has to create enough to sustain the department. And the good news is that with the growth that we've seen, we are able to do that. And one of the key components to that, as you heard from the other presenters, is shared medical appointments. We generally put 8 patients into our shared medical appointments. So within an hour, I see 8 patients instead of the 3 that I would see in clinic. We've had no denials to date, and we function with limited grant funding. We've attempted to get some funding, but the other piece is we want to have sustainability. So it's been really exciting for our organization to be able to create a sustainable program to provide this type of care to our rural population. With that, I'll turn it back over to Tyler for the Q&A session.
Wow, thank you so much, Dr. Finley, and to all 4 of our amazing presenters. This is such an exciting and timely discussion, and you've all shared remarkable insights and really inspiring results. So love those patient testimonies. Thank you for sharing. I see a flurry of really excellent questions and feedback in the chat. Unfortunately, we likely won't have time for all of them. So for our presenters, as I quickly walk us through the next few slides, if you want to review some of the Q&A that came in, type in any responses that feel specific to your programs as you see fit, feel free to do so. Before transitioning to that Q&A that Dr. Finley mentioned, we wanted to make sure that those on the webinar are aware of some of the resources we have available at ACLM to support some of the strategies described today. So one of the foundational ways to learn more about lifestyle medicine and food as medicine is to enroll in our complimentary 5.5-hour CMECE Lifestyle Medicine and Food as Medicine Essentials course. Which each of these leaders has socialized that within their networks and is available for free through mid-September. Simply scan the QR code or visit the URL on the slide to get started, and feel free to share with any others in your network. If you aren't already a member of ACLM, we would love to have you join. Our members are united in leadership to transform healthcare and make a lasting impact on addressing the root cause of chronic disease. Today's presentation is a really wonderful example of the type of impact that many of our members are able to cultivate. Feel free to explore the QR code for more information about becoming a member of ACLM. And we would love to engage with all of you at our annual conference, LM 2025, in Grapevine, Texas, as well as online. There will be some really amazing content pertaining to this topic and to a broad range of related topics addressing chronic disease and optimizing health through lifestyle intervention. If you can't make it in person, the online option is a wonderful way to plug in and also complete live prerequisites for board certification and invite your colleagues to learn more about the field as well. Which leads to our final resource slide. There are more than 8,000 physicians and clinicians globally who've become diplomates of ABLM, IBLM, or ACLM, including each of our distinguished presenters here today. So becoming board certified is an outstanding approach to gaining and demonstrating knowledge and implementing therapeutic lifestyle intervention within clinical settings. You can learn more about becoming certified at the linked QR code. And so now we have about 7 to 8 minutes left, and I'm going to turn back to our panelists for some live Q&A from the audience, and we'll probably stop sharing slides for this and just transition to faces. So as I mentioned earlier, there were some really outstanding questions in the chat. It's not possible to get to all of them today, but I've grouped a few of those for the four of you to respond to. And we'll start with hopefully a slow pitch, because I know all of you have done a ton to make your programs more patient and family centric. So we'll start with that question, and Dr. Kodani, we'll have you kick this off. What are some of the adjustments you've made along the way to make your lifestyle medicine programs more patient and family centric?
Great question, Tyler, and thank you for that. Currently, our Heal for Families, so that family-centric group shared medical appointments, is new. And so right now it is offered during the weekdays. After school is out, though. So it is during the workday, but typically in the later afternoon. So as we develop that program, we hope to offer more options for folks, but typically it's like Tuesday afternoons is where it is.
Thank you, Dr. Kodani. And I know all of you have done a lot of fine tuning. Anything else others would add?
I would add incorporating patients and your alumni into the work that you're doing. We found that incredibly powerful to give us feedback on the changes we need to make, on what additional secondary things that we offer. We have an alumni program that meets once a month, and it's been incredibly popular. We have to keep adding session times for that, and just trying to keep people engaged in being responsive to their requests.
Thank you, Dr. Finley. That's a great suggestion for everyone. And Dr. Mirsky, I saw you taking yourself off mute. Anything you'd add to Dr. Finley's remark?
Yeah, I'd say again, a key principle that our team has taken into account is understand where patients are at and what they want. We can all have lots of discussions about what we think is great programming and what's going to work, but for families especially who have different work priorities, different times of day they're working, childcare needs, and other caretaker needs, understanding your patient population and building programming that either meets for fewer sessions or more sessions, early in the day or later in the day. All of this is going to look different depending on who your patients are. So definitely encourage you to be open to what your patients and the families that you're taking care of really need.
Love this theme too, of really seeking that feedback directly from those that you serve and kind of fine-tuning the approaches to their needs. So Dr. Hunt, would you like to round us out with a response to that question?
Yes, on the same lines of like really listening to your patients, we do a Qualtrics survey at the end of every shared medical appointment, and it's a chance for them to just say a couple words of what they like and all. But some of the things that we've learned is that they actually request more information than we think that we sometimes think we're overlooking overloading them, but they're asking for more. And then also that is how we develop some of our other programming. They wanted deep dives into some of the details.
Wow, amazing. Thank you, Dr. Hun. Wonderful responses. We've got time probably for another question or two. And one of the themes that you probably all noted, there were a ton of questions related to reimbursement. And so I know each of you have likely encountered a lot of unique experiences along the way working with your billing and coding teams. And even as you've transitioned to virtual programs, some of those even touch on sort of privacy and compliance. So I think we'll just open it up to the group. What are some of your learnings related to reimbursement, maybe that you didn't touch on in your presentation today? And we'll go ahead and start, Dr. Mirsky, for this one, since quite a few of those came during your presentation.
Sure. Yeah. So the number one recommendation is be very, very clear with those in your organization, your clinic, your health system about what the guidelines or recommendations are. Having patients consent to and appropriately meet HIPAA compliance for group-based care is standard and has been standard in the US for decades. So this is not earth-shattering ways of delivering care, but it has to be clear to your legal team. And if you have any questions, just ensure that any consenting process or any information shared with patients meets the mark for them. It's different in every single system, so you have to ask. And similarly for billing and documentation, ACLM, the American College of Physicians, the American Academy of Family Physicians have all endorsed using 99213 and 99214 billing codes based on medical decision-making and medical complexity. So again, you are not breaking ground by asking your billing team to approve this and ensure that there's a pathway to do it. But I do recommend be very explicit and get it in writing that what you're doing is approved. But none of this should be a surprise because these types of care delivery pathways have been around for a very long time.
Amazing advice. Thank you, Dr. Mirsky. And also just thinking about, Doctors Finley, Hunt, and Kodani, each of you have kind of unique scenarios from a billing perspective, being located in the, rural health center, academic health system, Kaiser Permanente, that has its own kind of billing approaches. Anyone want to take a stab at anything that you maybe hadn't shared during your presentation, but that feels timely?
I
Go
can
ahead,
jump
Dr. Hunt.
Yeah, I can jump in for just one more comment. I would definitely echo exactly what Dr. Mirsky said. Make sure you cross those T's, dot the I's on all the documentation and all. My comment is that everything is driven by financial and even in an academic center, has been very powerful to our executive leadership to show the value. And so don't be shy of showing your numbers and making sure that you're showing the access improvement that you get with these numbers, and then also the financial gain that you get too.
Wow, amazing advice. Amazing advice. Anything, Doctors Finley or Kodani, that either of you would add to the beautiful advice that's already been shared?
I have to echo what Dr. Mirsky said, and he was instrumental in helping my program get started by sharing some of that guidance. Make sure that your coding and compliance teams are on board with this. Even with all of that evidence out there, it wasn't until we had local support from within the region. So they may want regional evidence of this. So, University of Wisconsin was able to help us out with that. So really get that buy-in, but then also be bold to share, like Dr. Hunt said, share the benefits of what you do. I've had people say, well, you don't prescribe any meds, you don't order any labs, because I don't do that. But demonstrating the downstream effects, and as well as the support for our organization, the different types of referrals that we receive, and just highlighting how this impacts patients. And if you have an opportunity to demonstrate the financial piece, we did a financial case study of one patient, but it has been tremendously impactful to share with the organization and wider, just to show how this can really impact. So.
Thank you so much, Dr. Finley. Really appreciate that. And to round us out, Dr. Kodani, final response to our final question before we end the webinar.
I don't think I could say it any better than all three other panelists. Just echoed what Dr. Mirsky said, and be proud of what you've accomplished, and definitely tout the things, especially the financial benefits that you'll see, especially for something preventative, even more important. Takes time to see sometimes those benefits, but they are absolutely essential, cornerstone of what we do.
So well said, all of you. So amazing questions and responses. What an outstanding presentation and discussion. Imagine we could continue this conversation indefinitely, and based on the chat, I think a lot of us would like to, but given that it's the top of the hour, we'll formally close today's webinar. And once more, on behalf of ACLM, I just want to thank each of our distinguished presenters for an incredible discussion, for the work that you lead, as well as everyone in attendance for being so engaged and asking amazing questions. We look forward to connecting with all of you as you bring some of today's recommendations and insights into your work, and we'd love to help you along the way. So in the interim, feel free to visit our Help Center and website for any outstanding questions that we weren't able to respond to during the webinar. And thank you all for being with us today. Wishing everyone a fantastic afternoon ahead. Thank you all. Take care.